This computer. Hi, my name's Robert Cody Owens. I will be giving you your peer instruction on, and let me pull up the slideshow. All right, so it's how to identify and respond to medical emergencies. A quick how-to, and it's up to you. So this is going to be a little bit of a CPR course and a little bit of like basic life saving or first aid skills and I'll throw in some advice on, like little pointers on what you should do and things you should probably keep stocked in either classroom, workplace, or even at home to, you know, better prepare yourself for a medical emergency. So first off, we'll be going over a review. The first one will be cardiac arrests, stroke, diabetic emergencies, seizures, traumatic injuries. We define the situations, I guess, more so the illnesses, pretty much how to identify them and how to respond to them and how to help the person having that emergency and how to contact and communicate with, the 911 call takers and personnel when they show up in the ambulance or in cop cars or fire trucks and to uh, be able to give them as much information as you can. Sometimes you don't, a lot of times you don't want to be there and just stand around like, I don't know what happened. He just fell. You want to be able to tell them exactly everything that happened, and try if you have enough, I guess, the ability to, you want to kind of mark times, like if you're on your watch or your phone, just kind of look at what time it is and see how much time has passed, during events. But, I'll kind of cover that a little bit later. So first off is cardiac arrest. So cardiac arrest is, of course, when the heart suddenly stops and unexpectedly stops beating. This is also known as ventricular fibrillation or the cease of the ventricles of the heart. They stop pumping and then, the rest of the heart kind of fails. And so does the rest of the body. So the VFib or the electrical system malfunctions, the heart pumping stops. This is caused by arrhythmias. So if you hear anybody who has ventricular tachycardia, atrial fibrillation, or any sort of any sort of heart condition, you usually will kind of throw it off. Very rarely is it, due to a atherosclerotic coronary incident or like, a clotted uh, blood vessel, but that does cause heart attacks. But the main ones you'll see are the issues and the electricity of the heart. Let's see. So, okay, so yeah, like I said, it can be caused by the blockage in the heart. So I'm kind of like going fast myself, making sure I'm covering everything. So then the one with the block, the atherosclerotic block, is usually uh called an infarction, and it's just a clot that just gets lodged in one of the coronary arteries and blocks blood flow to that tissue, and typically that tissue does die. Like there's some, if the if you intervene with a heart attack soon enough, call 911 soon enough, and get in the hospital, and they engage uh, and measures to help save the patient, you can sort of regain and save some of that cardiac tissue. But for the most part, a good chunk of the heart or portion of the heart will die after these incidents, and then there will be deficits afterwards. Just let you know, like after a cardiac arrest, no one's gonna pop right back up or ever really be the same. But there's a lot of people that do pop back up after a heart attack, and maybe they kind of like have a change of mind and they start changing lifestyles and they do improve themselves. But like I was getting at, like it's not they're not really 100% better. A couple weeks down the road, it'll take time after the event. So signs and symptoms of a cardiac arrest. Will be a collapse suddenly, not breathing, ineffective, gasping for air. So they'll be more times than not they'll be on the ground with no pulse, and either they won't be breathing or they'll kind of be agony breathing, and like you'll know agony breathing when you hear it. Like it is the sound of someone dying like that. Like, I can't replicate it, but you know I'm getting that. All right, so down here at the bottom is a automated external defibrillator. you find these in any building, especially around school, gyms, any sort of like large business. You can find them at Target. I found them like if you go near the either the restrooms or like the uh shoot the customer customer service desk. It's either one between one of those two places, and then Temple usually maybe on our first floor near the elevators. Like just kind of like be on the lookout for these little boxes. Like you'll notice them, and then there'll be like Phillips brand, Zoll brand. They all some of them kind of like the procedures in which to operate them will be different. But nonetheless, when you turn it on, it will prompt you to a voice prompt on what to do. Excuse me. And hang on, sign something. We should be covering this a little bit later. All right. So in the event of a cardiac arrest, you witness somebody fall. Sometimes it'll just look like they tripped and fell, or they just collapsed or fainted. And then sometimes you will see like the clenching of the chest and whatnot. And like I said, that's more so what you'll see in like an infarction. But it's the clenching of the chest, the sweating, and whatnot. Because usually, sometimes, more times than not, like if someone has a heart attack, it's like that. It's just the VA nodes just stop, and then you go up from there. So pretty much what you're going to do is going to roll them over onto a on their back or supine position. If they're kinked over like that, you want to straighten out their neck. Pretty much you can rough them up, shake the like beat them on their chest, shake their shoulders. You can stir them around and whatnot, and say, hey, are you okay? If you know their name, say their name. And then this would be one of the times if you see it happening, or if you're the one engaging with the person in cardiac arrest, you would want to kind of mark the time. If you don't, if you forget, whatever, just kind of be aware of how long everything takes, because that will be something you would want to be able to report both to probably the people in the 911 call center, but more importantly, the responders showing up on scene. And then so they'd be able to tell the hospital, and that paints a better picture for, the plan of care. Um, so then you're going to check for pulse and breathing. So pretty much what we're taught is you put your fingers on the pulse, and then you get on your knees and you're listening to, like you're putting your ear right above the mouth and the nose, and you kind of like trying to see if you can feel anything, in your ear and or on your cheek as far as air passing through, or listen for any breathing. And like I said, like definitely like if they're doing like the diagonal breathing, you already know it's a cardiac arrest, unless they're just they were choking, which again that would still lead to a cardiac arrest, but that's more so due to respiratory failure. So you check for the pulse, have someone call 911. If you're by yourself, you gotta call 911. And then if you have some bystanders, tell them to go look for that AED. And like I said, like check by elevators, check on the first floor. Like Temple has the security personnel and whatnot, and like you start screaming to the mountaintop for somebody to come help you and find an AED. You want that right now. So pretty much it. In that same time that you have someone call 911 or get the AED. And in the event if there's no one around and you have to call 911 by yourself, and say you're just the only one there, just don't stop doing compressions. Just keep doing compressions, and hopefully somebody shows up with an AED. Uh, More time than not, if you're alone, completely alone, like luck would have it, you're doing compressions until responders show up, and then they'll have an AED and all that. They'll switch out with you, and yeah. So you begin 30 compressions. You do 30 compressions and 2 breaths. So you don't have to do rescue breaths. Like, I know it's kind of disgusting that no one has like a pocket mask or a valve mask, or at least a mask with a stem where you can blow into it. So if you don't want to do the breaths and you feel kind of weary or whatever, just do compressions. That's fine. You just do compressions, and you do them for you can do 100 to 120 compressions a minute, and I'll have some songs or rhythms that you can follow. But if you just decide to do the breaths, you want to do 30 compressions, 2 breaths, and then if there's no AED, maybe reassess for a pulse after 4 rounds of doing compressions. Or if you choose to just do compressions, like give like 2 minutes of or a minute and a half, so 2 minutes of compressions. You can count them out. 120 will put you about about a minute and a half. So like I said, it's like 2 rounds of that. And you'll be pumping fast. And so another important thing is to keep in mind is the chest recoil and the chest depth. So by textbook, you're supposed to go. Oh, hey, see if I'm talking ahead of myself. Yeah. All right. So yeah, I'm talking ahead of myself. All right. So so you want well, this would be better. So you place the heel of your hand on the forearm of the chest. So you pretty much it's gonna be right here in the middle, like down towards the lower, because your heart be your ventricle is gonna sit about right here, maybe a little higher. And you're gonna be pressing. And just a fair warning, there will be cracks, pops, and you'll break bones. And just keep in mind that the price to save them. Like there's a price to be paid in doing CPR, and that's the broken bones and the cartilage and whatnot, but it'll heal. Don't worry about it. And if you really feel iffy about it, you're protected under the Good Samaritan law. So unless you do something completely grotesque, if you're, you know, in good mind, conscious, like making an honest effort to save someone, you can't be tried. I I'm a licensed provider, so if I sort of don't perform to my level, perform outside my level, or don't perform adequately, I could be tried, especially if I'm on the truck. But if I'm kind of a bystander, it's a little like technically I could be tried, but not really. I'm still sort of more so good Samaritan laws. All right. So, anyways, heel to hand on the chest in the center. You want to put, I kind of do like that. Everybody does a little bit different. I put the dominant hand on the bottom and I drive with the heel. And you'll kind of figure out like you're not really like pushing like when you're on your knees on them, you're kind of like for me I'm big, I'm 230, so I mean I'm kind of just rocking, and that's enough weight to really just kind of do enough deep enough compressions. And like I said, the depth is important, but what is more important is the chest recoil to allow it all come back and restart that sorry, the pressure and all that. So the depth for adults, let me see, I'm not gonna ahead of myself. Yeah, so the depth for adults is about 2.5 inches, and then like the max for like children, like pediatrics and whatnot, not infants, is probably about right at 2 inches at the most. And then pediatrics, you're pressing with your finger and you're barely going, not even an inch in. And uh, you definitely want to take an actual CPR course. It's kind of just down to like typically like in these workplaces we're dealing with adults, so you know I'm teaching more so adults. But if you want to learn pediatrics, then you can kind of look it up or take a like a Red Cross sponsored CPR course or American Heart Association. And see, but on the of the BG song right here, and there's a 120 beats per minute metronome. So if you want to teach yourself and kind of get that rhythm down as to how fast you should be going. Like 120 is the max that you should be going. You don't want to be cranking too fast, so you're not really going to get full uh, compression and decompression of the heart and lungs uh, with every compression that you make. So make sure you're getting all the way up and all the way down. And when you do CPR on like the mannequins, like the clicking is good. Like the clicking, like lets you know that you're reaching the depth. So this is more on the AED. So the AEDs are all very self-explanatory. Like the ones down here, like they'll have pictures on it, and then like there'll be a little pamphlet, like a looks like an in-flight pamphlet that you pull out that tells you where your seatbelt, but this will tell you where to put the pads on the patient. And then so this shows like a pretty good representation as to why the pads are placed to where they are. You're putting it on the upper right portion of the chest, and then pretty much on the left side, like it's showed here, you're gonna wrap it around just just below the breast uh, on the left side, and that's going to strike right to the apex, and that's where the ventricles set, and that will hopefully deliver a shock. And you may need to uh, deliver a few shocks, and in between shocking, like as you say clear when you administer your shocks, and the AED prompts you to. Excuse me, when AED prompts you to, and you clear it out, hit the shock button, which is look on this one. It's like right here. Oh no, it's down here. Sorry. Yeah, it's down here. Oh shoot. Oh yeah, it's down here. Um, and they'll deliver shock. And like the AD will prompt you, like, like deliver shock now, and then that's when you say clear and all that, and then you hit the button, let the shock be administered, give it about a second, and then you go right back to unless it says analyzing rhythm, like it'll say either analyzing rhythm or continued compressions. If it says analyzing rhythm, don't touch the patient, give it about like 10, 15 seconds. If it doesn't tell you anything, just go ahead and start doing compressions, because you like 10 seconds at the most. I'd say 15, just give it a second, but we'll say 10 seconds. Leave it 10 seconds. It's 10 seconds, you want to lead them without any sort of compression or shock being administered within 10 seconds. And yeah, we'll move on. I got a little video we can watch as far as I'm gonna check my time. A little video you can watch. So this is like the EMT, like by the books, like when we do our psychomotor evaluations, like this is like everything that goes into what we should need and should know what to do on the event of a cardiac arrest. Um, okay, so for things to know about cardiac arrest and the initiation of CPR, as CPR can't wait. Each minute CPR is delayed decreases the survivability odds of the patient by 10%. Also, delay in CPR, or like I said, like earlier with the waiting for the analysis of the heart rhythm and whatnot. Pressure seconds, waste pressure cells, and then from cells lead to tissues and organ systems. And the longer they go unperfused and underperfused, the more they are likely to fail down the road, even if the patient is resuscitated. Um, bystander CPR doubles or triples the chances of somebody surviving. You don't need to be certified in CPR or trained for CPR. There are jobs that require you to be certified and trained, but if you just know through this class or know through someone else or just kind of know through watching videos, then go ahead. Like I said, you're covered by Good Samaritan laws and a hefty amount of other things. And I'm thinking about this video I watched where like some man saved the woman from choking, and the woman tried suing him, and the judge was just like no, you know. But like I said earlier, don't worry about mouth to mouth. If that grosses you out, if you have some strict, personal, religious or whatever guidelines or whatever for, stopping you from really wanting to do that, that's fine. Just do compressions. Um, like I said, don't worry about hurting them when you're doing compressions. It's fine as long as you're not doing anything grotesque. Like you're gonna cause some harm or some something to the patient. It's part of it. Uh, like like I said, as far as like laying them on their back, so they're like they're face down in some awkward like construed like Family Guy, position, like just rolling on his back, like nice and straight, like you would think like a mannequin or a little I guess dummy to look, just like nice and flat, straight on the back. And I guess another thing I should say is about the airway when doing CPR. If you do decide to do mouth to mouth, or if you do decide, if you get a hold of a bag valve mask and whatnot, or if you have some sort of oxygen apparatus, say like the not the VDM, but yeah, I just call it an oxygen mask. The oxygen mask is a little bag on the bottom. You somehow get a hold of one of those, you can place on there. It's not really going to have much flow, but it's something. Because when you're doing those compressions, like there's that positive pressure, that positive negative pressure causing a little bit of movement of air. So they'll get a little bit more concentrated oxygen, and maybe that'll kind of help them save something in the long run. Uh, man, yeah. So and there's different things I'll show later in this presentation about opening the airway, because pretty much like if they're laying flat on the ground, like they're kind of like this, like they're pinched because they're laying on the back and their head's flat on the ground. So the next pinch, they're blocking their trachea, and there's not much airflow. So what you want to do is do the head tilt, turn left, kind of open them up, and like you'll kind of see it. Like if you do it on a dummy or whatever, like naturally their kind of jaw will open up a little bit. Like it's not gonna work, but it will enough to like see an opening, and you can be able to give breaths or pump it to the back valve mass a little better. And I'll show later on like how to do a jaw thrust if say like you suspect that they that they got in a car accident, and then that, led to their cardiac arrest, which would be a traumatic cardiac arrest. You know, um, you wouldn't want to move their neck around too much. Or say if they like fell and like you just got an awful feeling that, they did some damage when they fell. Say like, when they had a cardiac arrest, or say like they, arrested on a set of stairs and they fell down the stairs. You'd probably want to opt in to do the uh jaw thrust as opposed to the head tilt chin lift. Like I said, I got some pictures uh later on how to do both of those techniques. All right, so next would be strokes. All right, so the acronym that you can follow is be fast. Let me see if I can kind of move these bars and whatnot, move myself. All right. So BFS stands for balance, which is a sudden uh, feeling or sensation, or they exhibit that being dizzy or a sudden loss of balance. And eyes, if they say they have double vision, or if they lose vision in one eye or both. Face drooping is like the typical stroke presentation, like it looks like Bell's palsy or whatever. They have a droop, sometimes it'll be both the eye and then the mouth, and you can kind of see it sag right here, and you'll see like this have its shape, and then this will be straight down. It's different presentations, and they're not all the same with everyone. Uh, Arm weakness is another one, arm leg weakness, and pretty much the speech difficulty. So it could be aphasia or aphasia. So one's like sort of like you're you know what you want to say, but you can't say what you want to say. Like your words just don't make sense, and sometimes you're not necessarily slurring, but it's aphasia and aphasia. But like I said, they present with different areas of the brain that are affected. But one is mixed words, and one slurred words. Uh, but then the other one is understanding uh, words, because the stroke is it's either a clot or a bleed. I should have addressed that earlier. Give me a second. And then time to call 911 because the tee off of B fast. Yeah, I'm kind of all over the place. So call 911, just like, hey, I think my mother-in-law or my coworker's having a stroke. I just need somebody over here. And then they'll ask for the age, the age, give them the age. If they don't, just guess. And give them an address. That's it. If you don't know, it's okay. Just give them as much as you can, make it quick, and then they'll send somebody over. And so there's hemorrhagic and ischemic strokes, and there's TIAs, which are transient ischemic accidents. So we'll start with TIAs. They're the least, uh, I guess, they leave with the least amount of deficit with the patient. So like they'll have a stroke and they'll present with a lot of these symptoms, and then more times than not, before we even show up, it's gone. And that's not to say that the stroke's completely gone. It's just that it was a small clot. Maybe like their blood pressure jumped and the blood pressure pushed it through. And it's good and bad, because there's a possibility it just moves that clot further down. And so just a handful of times they'll go respond to a stroke, and they'll call in line like my grandma's having a stroke, and like what they told us happened will be everything a stroke would look like. And we get there and the lady's just full full symmetry, which is good. Talking to us, she knows everything that happened, just maybe a little chicken up. And like I said, it's always better to have them looked at afterwards. So next would be the ischemic, which is similar to the TIA. It's still a clot. And then, more times than not, say like 5, 10 minutes it takes us to get dispatched, get down to where your house is. They're still presenting with it. Maybe it got worse, maybe it got better, but they're still definitely presenting with it. So when we get there, we can conduct a Cincinnati pre-hospital stroke scale, which is usually like we walk in there and we're like, we'll go ahead and grab your grandma or grandfather's hands. We'll tell them, go give us a squeeze, and we'll tickle their palms and tell us which hand we're touching, because that sometimes they'll switch up, and we'll tickle the right hand and they'll keep saying left. And I'm like, are you sure? They're like, yeah, left. And I'm like, all right, we'll get in the truck. And then there's that one. There's the arm drift, and so we'll pick up their hands and tell them to hold their hands all straight, and close their eyes, and then we'll count to like five, but we won't tell them to count to five. The trick to that is don't tell them to that you're counting. Just tell them to do it. And then more times than not, because if you're counting, they're really fighting it. Like, and they're like, yeah, I gotta keep straight. But if you don't, if you say like you wait 5 seconds, you just tell them to do it and let it go. More times than not, if there is a deficit, you'll see it. Like the arm will just like, sometimes it'll be like a little bit. Sometimes it'll just flat out fall. It depends on the severity. The face will droop. I don't know if I went over that. So that would be like, we go in there and tell them to give us a big old smile and all that. And like, there's a deficit, you'll be able to see it. Add normal speech. So, have them say something that, they've probably said 1,000 times before. Like you can't teach an old dog new tricks. And then, if they have a stroke, like they'll slur it or there'll be, they'll use the wrong words or they'll mix up the words and whatnot and move on from there. And then you can do the feet, which is pretty easy. You have them like pick up their feet, you put your hands underneath their feet, and then you have them. We tell them press the gas, and like we have our hands sit underneath their feet. We tell them just push down on our hands, and like if there's a deficit, like the amount of pressure they can push with the feet is indicative of a stroke. And then we'll put our hands on top of their feet and tell them to pick up their feet. And if there's a deficit there, it may be a stroke, but we understand like the older you get, the less you can move. So, some fine motor skills like that, may be difficult. But yeah. And so the last is hemorrhagic. I had a nasty one for the nursing home on Friday. And sometimes that looks like they syncopized or they passed out or it kind of looks like a heart attack. But more times than not, you can obviously still see them breathing. They're just not responding. And then this is the hemorrhagic is the brain bleed. It's the most I guess like dangerous of them all. And because the bleeds will cause shifts in the brain, and once there's a shift from all the pressure, there's very little the doctors can really do. And once that shift happens, it's really difficult to go back. And the guy that we had, like what you'll learn later on if you do with like first aid and whatnot, with hemorrhagics, like they'll look at it. Like you'll see like their eyes like rolled one way or the other, like straight back, straight to the left, like to the right and back. And like you'll see it. Like they look at the bleed. And but they're unresponsive. And generally with that, like their blood pressure's through the roof. Like the guy that we picked up was like 214 over 160. Like it was insane. But yeah, and then like I said, try to mark the times of when everything happens, and try to report all that to the 911 personnel that you call on, especially the 911 personnel that show up on scene. All right, so the next is diabetic emergencies. So there's two types. There's hyperglycemic and hypoglycemic. So hyper is, of course, high blood sugar, typically above 150. But even if you are, especially if you are diabetic, uh, you will always be outside normal ranges. And like your baseline glucose level could be like 210. And then, like if you're no diabetic, you're sitting at 210, we'll ask you, is that normal? And you're like, yeah. And I'm like, all right, cool. And then we'll just ask them how they feel. And then, but generally for like hyperglycemic to really be like a hyperglycemic event, it's like 300 plus. Like, and definitely if you're like sitting above 400 or 500, I've seen well over 600. And that's when, that's when they're pretty much unconscious. They're sweating, they urinate themselves. And the last two that I had, they had seizures. And so the hyperglycemic are the signs and symptoms down below. Like I said, they urinate large amounts, they're sweating a lot, they smell fruity, uh, excessively thirsty. So if you see someone who's a known diabetic or someone that just seems like they're like, man, I'm thirsty. I just can't kick it. And they don't seem to have exercised or done anything else or consumed any drugs to make them a little extra thirsty. They might be having a hyperglycemic event. And if anything, you can have them check themselves out, or if you have a friend in the office or whatever that has a glucometer, maybe they'll let you borrow a test strip or something, a Lancet, and see where you're at. And then another thing is feeling tired. And like I said earlier, the main concern with like letting these sort of events prolong is seizures. Excuse me. And then so continue on. Trying to figure out somewhere to do this damn toolbar. Sorry. Uh the next going on with the diabetic emergencies is a hypoglycemic event. And that's typically a drop below 70. And this is where you kind of have like a lot less playroom than hyperglycemic. Like I've seen people who are like at like 60 for their blood glucose level, and they can't tell you what day it is. And they're pale as cats for the ghost, and they're just like they look like they're nodding off, you know. And like I said, everybody's a little different. Some people can sit at 60 and be perfectly fine. Uh, so this is, you know, presents with lethargy, somnolence, you know, tired or whatever. They may look intoxicated. So we've had there's a joke that we always say around the EMS, you know, making fun of police, always Narcan everybody. And there's been events where cops not, you know, in the local that I work with, just cops in general, Narcanning people having hypoglycemic events and, you know, treating them like they're under the influence when they're just undernourished. So you know, the person that's, you know, having the event will also may seem irritable, you know, taking the hangry to the next level, and they may exhibit uh shaking. You know, I've seen people who are starving and whatnot that have low blood sugar, they'll be shaking. They may feel like they have tingly lips, and they'll be dizzy. The irregular heartbeat can be assessed on a monitor, or they can, you know, you can feel it yourself sometimes if you're having like a super irregular heart rhythm. You can feel it. The hyperglycemic could also lead to seizures, but I've seen it to where they just kind of like they go unconscious. But I don't think I've ever seen a seizure from a hyperglycemic. But the hypoglycemic event, if left alone long enough, could lead to death faster than the hyperglycemic, because you know the body's, you know, burning off this little bit of fuel source, and if it depletes, it depletes, it's done, and there's no like restarting it. And so that's something to keep in mind with all that. All right, so moving on. All right, so we're going to go over seizures, signs and symptoms. So there's the absent seizures. So drawn by hyperventilation or flashing lights. So this could be, you know, along with epilepsy and whatnot, or just in seizures in general. You know, this is presented with a sudden halt in activity. So, you know, you're just sitting there hanging out talking, and someone's just locked. And like, you know, you're saying their name for like good like 10 seconds and they're just gone. And that could be that's an absent seizure. Like there's no like activity. They just stop. So a focal seizure is, you know, someone's just aware of their surroundings and they may be able to hear you, but they won't be able to really respond or respond appropriately. And then so, you know, they may report funny visuals, smells, and tastes. And then so sometimes this also is like indicative of someone's aura, or, you know, what happens right before they have a seizure. So the generalized tonic-clonic is what we usually see in seizures, say like on, you know, I guess in real life or just on TV. And that's the, you know, the sudden stop and activity, and then the drop and the shaking and whatnot. And, you know, these could be on and off. It's not all, you know, it could continue on for like 10 seconds. It can continue on for, you know, 3 minutes. Anything above 4 minutes is generalized as a, hang on, make sure I'm not, okay, so it's in oh shoot, going ahead. So anything beyond 4 minutes is status epilepticus. And EMS pretty much, if they don't regain consciousness and talk to us and they keep going in and out of seizures, that's status epilepticus, because they're not really out of the seizure. It's just kind of coming in waves. All right, so responding to seizures, you want to protect their head and airway. So, you know, especially if you have like the people who are, you know, having a generalized tonic-clonic seizure, you know, to hopefully try to protect them from like falling and smacking their head. Or if they do already fall and they fall to the ground, kind of protect their head while they're having the seizure, so not repeatedly, you know, beating themselves on whatever surface is nearest. Put them in the recovery position. This is typically on their left side. As you see in the picture, the left arm's kind of bent like that. The right arm's supporting the cheek to kind of keep the airway open and then keep them from swallowing their tongue. And you put the right knee over the left, and then that kind of stops them from rolling over in your stomach. And you know, you don't want to leave them there as far as like alone, but you know, kind of hang out with them, make sure everything's good. Because if you know, a lot of people when they do convulse like that or have seizures, they typically do throw up, and you don't want them to aspirate on their own vomit. Um, yeah, that's it. Like I said, protect their airway, protect them if you can. Try to like find some way to keep them from locking down, but it'll happen. And that's what I got our little maneuvers to do the head tilt chin lift. We actually just had a seizure. Well, it was an overdose that led to seizures. But yeah, say seizures. I had a firefighter in the back of the ambulance with me, and the other firefighter driving. And we're over there working this little girl, and I had him bagging her, and he said he couldn't get anything to go through. So I showed him how to, rotate the head back for a head tilt chin lift, and she was still locked. And luckily, she wasn't that bad to where all I had to do was just, grab a hold of the cheekbone or the jawbone and drive it down, and that opened it up to where he could do the ventilations. And I know it sounds all rough and like you're, you know, uh, abusing them, but it's all part of the process. So next is bleeding, traumatic injuries. So the types of bleeding are venous, which is a steady flow, usually from cuts, lacerations. You probably cut yourself plenty of times before. I know I have. I'm a clumsy son of a gun. I've cut myself in many stupid situations. About darn near cut the tip of my thumb off just closing a pocket knife. Like you can't trust me. Capillary is oozing, typically with scrapes or abrasions. Somebody falls down, skins their knees, elbows, and even their face. It's just kind of ooze. And sorry, I live right after cop. It's a little busy out there. The last is the most dangerous bleeding is arterial, and that's generalized. Or like say like you could have your femoral artery. Shoot, you can't see me pointing at the screen. Your femoral artery run down this way through the groin area, down to the bottom of the leg, all along the femur, and or it could be out of the arm. It could be right out the inside of the armpit, which armpit kind of suck. That's kind of hard to tie off with a tourniquet. On the inside, like I said, the arterial is the like you'll see it, like the body's just ejecting blood, and it's it is traumatic because it's from a traumatic injury. But anyways, so for venous, you can you depending on how severe the cut is, you could benefit from kind of putting a tourniquet style, you know, apparatus on for a few minutes while you bandage it up and kind of get it to create a clot, with the bandages. You'd probably use a collection of any sorts. And if it's small, you just throw something on there and just leave it at that. And capillary, you probably want a big old bandage like this to cover up a large area and then wrap it up. And you want to sterilize it before you bandage it. And so this picture's for to kind of like make a makeshift tourniquet. This is kind of like a t-shirt or rag that you cut a good size strand on, wrap it up, and use like a windlass almost type deal stick to crank it down. We can use a belt to like cinch it down. Or they tell us in the Marine Corps, especially if it's femoral, like say like they're mid lower legs blown off, or it's a good chunk missing out of it, and they're gushing blood. Is you can put your knee right inside that femoral artery on the crotch, and like you just draw, like you sit there and you put your knee right in there, and if they're conscious, they'll be screaming, but it is what it is. And you can do about the same thing with arm injuries as well. It's kind of hard. You can't really drive a knee, but you can kind of hold it and figure out where the artery is. You try to slow it down. I don't think really find your thumb and find your arteries kind of really completely cut off blood flow, but maybe we'll slow it down. And yeah, and then so pretty much if it's maybe advanced bleeding and whatnot, and you put the tourniquet on for like 5-10 minutes, really kind of establish a clot, slowly release that pressure and let it sort of get the flow back. And yeah, like you don't want to leave it on too long. But then again, if it's like an arterial bleed, leave it on. They may lose a limb if it's a couple hours later. But it's better than bleeding now. All right, so this is for like fractures, uh, more so for fractures, concussions, and spinal injuries. With this for like doing a sling and saw for like the forearms maybe fractured. Especially we do this for like dislocated shoulders. What you kind of doing is supporting the shoulder to be tied like higher and more so towards to the person with the affected arm or shoulder to keep it from bouncing around. So you move around because that bouncing around is just gonna do nothing but uh cause more damage and cause more pain. Um, so the best you want to do is keep the injury in place. These next couple of things, there's like a newspaper, a plank of wood, a stick. You want to use all these to kind of say like the arms fracture, the legs fracture. You want to keep it aligned with the bone. You don't want to. So if say like you see the bone kind of sticking out, either completely out where it's a collarbone fracture, or it's enclosed, but you see the bone kind of poking at the skin. Don't move it. Don't reset it. Just support it with the sticks, the newspaper, whatever you kind that's nice and flat and runs along the leg or the arm, and just keep it nice and straight on it on both sides. And then you want to wrap it up. All you're trying to do is just keep that bone from moving. And then the next thing with spinal injuries is keeping that head in line. Keeping the control of the cervical collar and all the C spine, and just keeping that head straight and aligned, and trying to mitigate any movement from there. It's really hard if they're awake because they may be not paralyzed. They may be shooken up and really just want to move and see what's going around, which is normal. But you got to remind them to not move. All right, so the next goes along with concussions and brain injuries. So beyond like the normal headache, blurred vision, and everything you may see with a concussion, depending on what area the brain is affected and how bad it's affected is the posturing that you'll see. So this is sometimes you'll see these in like fight videos or in a fight themselves. The person goes like this, which is still sort of it's a brain injury. It's usually pressure on the foramen magnum, which is where the brainstem feeds into the skull. And the cerebellum, the reason it's in red is if they posture outwards more so. That's a worse sign that shows that the brainstem is affected. Could be torn, severed, or just swollen. And the brainstem controls the breathing, and of course, the breathing goes, the heart goes. So the more deadly of the posturing, and the more needs response now will be the cerebellum. And then so this will be with the concussion. So this is the head tilt chin lift I was talking about earlier, and this is the jaw thrust where you kind of just sorry, I'm trying to move my screen so you can see me. You're using your thumbs, you just draw like you're driving it through. Like there's no easy or delicate way to really do this one. The head tilt chin lift, yeah, sometimes you gotta like really move them, especially if they're like a full size adult, like their head's heavy, like move them. And this is for like no suspected brain spine stem injury, and this is the lower ones for suspected injury. And then this is signs, symptoms of concussions, the nausea, decreased reaction time, vomiting, mood swings, all that. So we'll do a quick overview on overdoses. Since this is intended for a college. And I know Philadelphia has a huge push for using Narcan. And one of the first things that I want to state as far as Narcan someone is they become agitated. So you can try doing like the 2 milligram dose, try to get in both nostrils and leave and call 911. Especially if you don't know them. Like if you just see someone kind of leaving, I wouldn't completely leave them, but just kind of like monitor them, see if they're kind of moving around, breathing and whatnot, call 911. Like I said, there's a handful of them where, they're not right. And, a lot of mental illnesses lead to drug dependency and drug addiction. So, they weren't really right to begin with before they even overdose. And then especially when they're coming out of that overdose, like you ruin their high and they're going to come out swinging. Either that or vomiting, which is, in my opinion, worse. But still, especially if it's a friend, protect their airway. This can be with opiates, alcohol, hallucinogens, if they just seem to be unconscious and whatnot, sort of just kind of going, call 911, protect their airway, keep them open. And if they're, especially like maybe, well, I guess with all these overdoses, it could induce vomiting. So just kind of maybe put them in that recovery position. Uh, and then so with like hallucinogens, you don't really see people presenting with like dropping and not breathing and whatnot, but they usually start bugging out. And unless you um unsolicited, sort of I didn't say this, but if you have some benzos or somebody's prescribed benzos and they're on high on hallucinogens, give them one. Especially if it's a low dose, give them one. It'll take, about a half hour to digest, but that'll take them right out of it. But that's my unprofessional, unmedical, just street knowledge. Uh, especially like I don't know if it really affects marijuana, but like especially LSD and psilocybin and stuff like that, it'll get them out of it. And then and then with any of them, if you see them kind of just declining any sort of sense, encourage them to hydrate. Maybe get them out of the situation they're at, like at a party or whatever, and give them some fresh air. Just get them outside, especially get them away from people, because they're not in a sober right state of mind, and every little thing could kind of upset someone in that sort of situation. Excuse me. And then of course, like I should have mentioned this first, and the first bullet is protect yourself. Like I was saying, like they may become agitated and whatnot, and if they become too violent, aggressive, and they want to fight, or if they want to run away, just let them. It's better to kind of just protect yourself, protect the people around you, and if they want to run away and they want to fight, kind of just do some non-lethal takedowns or whatnot, and just get them under control. And then definitely call 911 and have that taken care of. And don't be afraid to call 911, because more times than not, if it's an overdose, cops are cool and they'll just bring them back to the tank and let them hang out until they process it and kick them out the next day. These are my works cited, and I'd like to thank you for sitting through my lecture. You have a great day. Bye. We're still recording. Oh, it's still recording. All right, bye.